And so greetings as the and we seem to be in the dark once again as Foray Pavan comes to an end. We are going to be going live now with another very interesting program with my special guest, Professor Fofi Constantinidou, about neuroscience. Wondering why it was so dark. So a time check for 12:30. A reminder you're tuned into a RIC Classic 88.2. We are also now live on Facebook from my page, Saskia Constantinidou, and we are streaming on cybc.com.cy. You can also pick it up from my website, Saskia Constantinidou, and I'm very, very happy to have in the studio with me a very special guest, Professor or Doctor if you prefer. You have both accolades, Fofi Constantinidou, Professor of Language Disorders and Clinical Neuropsychology, also the Director for the Center of Applied Neuroscience. Your CV is practically a book with so many accolades and achievements. Your PhD from the University of Cincinnati in the area of speech language pathology with a concentration in neuroscience and neuropsychology. Your special interest lies in acquired neurological disorders and traumatic brain injury. And I was thinking it would be good to begin with maybe a definition of what neuroscience is and how it's connected with your other special interest of speech pathology. I know that you want to begin by introducing that.
Okay, so neuroscience is an umbrella term, and actually before I say that, I'd like to thank you for the invitation to be on your show, and good afternoon to our audience either on Facebook or on the radio. And it's an honor to be here.
Thank you, thank you.
Neuroscience is an umbrella term, and it refers to the multidisciplinary approach to the study of brain relationships and brain behavior relationships. It can involve a number of different disciplines with the aim to understand how different networks and systems of the brain work together for specific behavior, whether that behavior has to do with an action, a movement, or it has to do with an emotion, with language, with cognition, including memory, attention, perception. And so different disciplines contribute to the understanding of these activities. So we have people who are experts in communication disorders, like speech-language pathologists. We have people who are experts in cognitive psychology, people in computer science, who work on mathematical modeling, for instance.
Yes.
We have people in zoology, in pure neuroscience, who are looking at cellular types of activities and how the cells connect to form networks and how those networks connect to produce a thought, a word,
yes,
an action. So it's a multidisciplinary approach to our understanding. Now, when we refer to applied neuroscience, we're looking at applications of that knowledge. And this has led to the creation of the Center for Applied Neuroscience at the University of Cyprus.
Yes.
Where we have different teams of researchers. Some of us have also applied clinical work, expertise and experience, where we're exploring high incidence conditions, including language disorders, learning disabilities, behavioral difficulties, acquired brain injury, aging, dementia, and how those disorders relate to the brain physiology, brain
Yes.
activity,
Yes.
and also our ability to develop clinical treatment protocols to improve functioning for these high incidence conditions. But then, of course, when you're looking at disorders, you also need to understand the normal brain, the normal brain development across the lifespan. And so this is another area of interest in terms of how does the brain mature, what are the effects of age in children, what are the effects of age in younger adults, in older adults.
As you said, it's very broad, it's very wide. Is it important for neuroscientists to have rather particular focus? Because obviously, if you're looking at Alzheimer's, you can't be looking at speech pathology, and you can't be doing too many things, or am I mistaken?
Well, it depends on what is the question at hand. So depending on the question, that the research activity of the team, depending on the focus of the question
Yes.
of the team, then you have to decide what are the activities needed. So always when you're working on trying to find a solution, and
Yes.
especially when you're dealing with human behavior, a lot of times you have to incorporate the knowledge of more than one discipline
Yes.
to do so.
How is neuroscience different from neuropsychology?
So neuroscience is the general umbrella term, and one discipline that contributes to neuroscience is neuropsychology, because neuropsychology has developed from the need to understand which brain structures could be affected when we see a clinical problem in behavior. So neuropsychology developed in the early 1900s, mid-1900s, when we didn't really have the access of imaging technologies that we have now. And if you think about World War I and World War II were significant contributors to the development, not only neuropsychology, but actually to rehabilitation medicine. Because at that time, there were a number of soldiers who returned from the wars, and for the first time, there were more survivors than deaths. And these soldiers returned home with a number of physical, cognitive, language, and emotional problems.
Yes.
And so the field of rehabilitation medicine really developed at that time to address these issues. So neuropsychology developed from the need to understand when you have a patient that exhibits memory problems, which parts of the brain are affected.
Yes.
And so different types of assessment tools were created to assess memory and language and attention. And then with the onset of imaging, initially through simple x-rays, then afterwards with the development of CT scans, MRIs, PET scans, and so forth, these the ability to locate lesions has improved dramatically. But still to date, a lot of times we can have a normal imaging study.
Yes.
Yet we have individuals that demonstrate neuropsychological deficits. So there's still a need.
Still a need, and there's still a way to go.
Yes, yes.
Does the Neurocognitive Research Laboratory you created in 2008 at the University of Cyprus still operate, or did you replace it with the Center of Applied Neuroscience?
Okay, very good question. The Neurocognitive Research Laboratory preceded the Center for Applied Neuroscience. When we created the Center for Applied Neuroscience, and here I have to say that the center was funded through competitive funding by the Cyprus Research and Innovation Foundation. There was a call for proposals for strategic infrastructure grants that were in different domains. One was social science, the other one was health sciences, technology, etc. And when we submitted the application for the Center for Applied Neuroscience, it was to create this research center that would investigate high incidence conditions using the integrated methodologies that we use now. So the activities of the Neurocognitive Research Laboratory are highly integrated with the activities of the center. Our lab is one of the 6 labs that contribute to the center. The lab, though, is also a teaching laboratory for the students in psychology at the University of Cyprus. So while the activities are intimately related, there is a separate entity, albeit in the same geographical region as the Center for Applied Neuroscience.
Very impressive. I think that you must also have quite a lot of international interest.
We do. We have, as a center, as I mentioned, there's 6 different teams. Each of the teams is led by a colleague, a faculty member in the Department of Psychology. We have a lot of international collaborations.
Does the fact that the university operates in Greek hinder you in any way? And has the particular faculty thought of expanding to be English-centered? This
is a very interesting discussion, and I think it has some multiple ways of looking at it.
Yes.
Certainly, as a department, we are looking at offering graduate degrees in English. This is an area that we are exploring. Yet we are a publicly funded university, and so we do have a commitment towards our base, and our base is the students from Cyprus. So these are interesting questions that we are exploring. From a research perspective, because we operate in Cyprus, the participants for our studies that are hosted in Cyprus incorporate primarily Greek-speaking study participants.
Yes.
Now, our collaborations with colleagues from other countries, obviously their data is from other of speakers of different languages.
Yes.
And depending on the research question, then we're able to combine data to answer those questions. So as an example, we are partners in an EU-funded project on dementia called SenseCog.
Yes.
We hold multi-center clinical trials. The Center for Applied Neuroscience is one of the sites, and we collaborate with the European University of Cyprus. So there's 2 partners in Cyprus.
Yes.
The data that we collect will be merged with data collected in Athens, in Nice, France, in Dublin, Ireland, and in the UK, in order to be able to look at the effects of our treatment protocols through this project.
This is very interesting, and I'm happy to hear it, because frequently we hear about studies, and I look at and I read the research papers, and I see this was a study done, with 57 or 67 applicants, and I'm thinking, how broad a base is that when you think of the millions of people in the world?
Right.
Shouldn't studies, in order to be really effective, have a much higher number of people actually being researched?
Yes. So, and you bring up some really good questions or thoughts, in the sense that small countries like Cyprus, where we have a smaller population base, when you're dealing with clinical groups, oftentimes we do have smaller sample sizes.
Yes.
And the recommendations by the international community is to join forces with different centers so that we can create what we call high-powered studies.
Yes.
So that we can have larger sample sizes, and therefore we can, the results can have applications to a larger population. It's what they call in research external validity. So how are your results
absolutely
relevant
yes.
or applied to the larger sample. On the other hand, in Cyprus, we have some studies that are high-powered, where we have larger sample sizes.
Yes.
And that's something we've worked very hard at the center to create some high-powered studies through larger longitudinal designs.
Yes.
And we have one example is our study on aging, where we have large sample size, more than 100 people in the study, where we follow people every 2 years. And so now we're in the 10-year.
Those are fascinating, because you start these studies and you hear of them and you think, wow, what's going to happen, and to have the idea that you're going to have a study that's going to last for 10 years. I find that to hear about those results after 10 years fascinating.
It's fascinating for us as well. It's also a little sad at this point, because we're realizing that some of the individuals in the 10-year phase are no longer able to participate. Some have passed away. So we're constantly recruiting new study participants. And so that's a study that looks at language, cognition, biological factors, some genetic factors, and lifestyle factors for aging. And so it does require interdisciplinary collaboration.
Yes, yes.
So my background in communication disorders comes in extremely helpful.
Yes.
In that, for that particular study, because I'm able to integrate my clinical expertise along with my research interests. For the project. And so it's important, and then the study generates so much data that we have collaborated with colleagues in nutrition to look at, for instance, cardiometabolic factors and how they affect aging and cognition. We'll
come to that in a while. I'd like to discuss 3 acquired adult neurological disorders and their effects on intellectual and cognitive abilities: brain injury, aging, and strokes. If we have time to do that, if we begin with brain injury, what is an ABI?
So the term ABI, or acquired brain injury, is the term that refers to an injury to the brain that can be a result of a traumatic event, let's say a motor vehicle accident or a fall, or it could be an injury to the brain that is due to an event that can be internal to the brain, such as a stroke. Or it could be a growth, such as a form of neoplasm or cancer. So those are examples of acquired brain injury. And acquired brain injuries can result in significant burden and disability that can last for decades. Traumatic brain injury is a form of injury that is due to external forces that are applied to the skull and the brain. So it could be an inertia force that causes acceleration and deceleration within the skull, as in the form of a fall or a motor vehicle accident or a hit to the head.
Boxing.
For example, boxing. But also something that people don't realize is that you can sustain a traumatic brain injury without actually hitting the head, but could due to a jolt. So the example will be a shaken baby syndrome, where the brain, the head might not be necessarily hit, but the baby is shaken. Or it could be in a sporting event, for instance, when there is a collision between 2 athletes, but the head might not be part of the collision, but the bodies are jolted to the point where
so it's such a force that it actually shakes your head as well without actually having contact with your head.
Correct. So that results
that's quite frightening.
Yeah, so it can result to what we call a concussion, which is a milder form of traumatic brain injury.
Right. How does one identify if it's a permanent or temporary injury in order to assist with functional disability and psychosocial maladjustment.
Okay, so traumatic brain injuries are classified in 3 different severity levels: mild, which is also called a concussion,
Yes.
a moderate, and a severe brain injury. There are medical criteria as to that leads the physicians to classify the severity of brain injury. Those criteria include variables such as duration and loss of consciousness, the presence of and the duration of the loss of consciousness, the presence and duration of post-traumatic amnesia, which is the period where the person doesn't really remember very well, doesn't have very good connected memories.
Yes.
The findings of the MRI or CT scan, and the length of hospitalization. So those are criteria that are used to
Yes.
make the medical decision. There are scales that are used at the time of injury, such as the Glasgow Coma Scale, that is used a lot. And in all of the medical shows, you'll see people rushing and saying GCS score,
Yes.
and they
Yes.
give a number from 3 to 15. So there's a number of different medical criteria, and this is where fields such as speech-language pathology and neuropsychology come in to help, because, for instance, one of the criteria for a concussion or a very mild brain injury is that the MRI is normal.
Yes.
Yet the person may be exhibiting cognitive, linguistic, and other symptoms, and those symptoms are evaluated by a set of examinations that we have in our disposals in our fields of communication disorders and neuropsychology. So we have objective measures of language, of memory, of attention that we
Right.
administer to help determine the level of functioning of the particular patient in comparison to people of the same age and education level.
So you do a diagnosis in a way, but do you continue with therapy, or is that again team effort, and then you may send off a patient once you've diagnosed them to various disciplines?
Yeah, ideally, in a hospital setting, let's assume that the patient is hospitalized because
Yes.
their severity requires hospitalization. So ideally, at the hospital setting, the speech-language pathologist, the psychologist, the physical therapist,
They all work in conjunction with one another.
yeah, they will come in and
OT.
evaluate the patient, and then have a team meeting and determine a treatment plan
Yes.
depending on the needs.
Does this work in Cyprus?
Unfortunately, it doesn't work in Cyprus.
Because it sounds far too European and American. That you have a complete collaboration of people and teams actually helping one individual.
In Cyprus, unfortunately, we have very fragmented services. So there is one rehabilitation center, the Melathron Agoniston
Yes.
in Palodia, where about 30% of people with severe injuries go for treatment. But the majority of individuals with moderate traumatic brain injuries and more mild injuries do not receive that kind of treatment. Now, about 30% of individuals with concussion, which is the majority of traumatic brain injuries, will have sustained problems that extend for at minimum 3 to 6 months post-injury. So if you think about, that's a period where the individual is having difficulties concentrating, difficulties remembering. The individuals with concussion are typically younger people, younger adults, teenagers.
Does this delay in obtaining treatment actually hinder the progress?
There is research that suggests that by delaying treatment or not receiving treatment can set off then a variety of neuropsychological problems. Because sometimes there is a disconnect where the patient exhibits difficulties. They can tell that they're having a reduction in speed of thinking, a
Yes.
reduction in their ability to find the right words quickly, that they have mental fatigue, yet the MRI is normal. And so they might hear inconsistent comments from their healthcare provider saying, well, don't think about the brain injury anymore. Your MRI is normal. 2 months have gone by, so everything is good. So there isn't something medical they can pinpoint that they can see, yet the neurological cascade has occurred in the brain and it affects the functioning. And so this can create more anxiety,
Yes.
symptoms of depression that could have been prevented if we had intervened and helped the patient develop strategies to combat the memory and the attention and the language
Yes.
difficulties.
The AAN, the American Association of Neurology, last week released the results of a study where MRIs were used to measure the brains of people with different activity levels. And the results showed that exercise in older people was equal to 4 fewer years of brain aging. I found that particularly interesting. It's a study that's going to be presented in Canada at the end of April 2020, coronavirus permitting.
Yes.
And I'm wondering how much can be attributed to exercise, diet, and stress. In this particular study, they actually examined 1,557 people over the age of 75.
Okay. So the study is a testimony to the constant effort aiming to understand variables that contribute to healthy aging and healthy brain health. And there is great interest in the last 20 years to understand modifiable factors. So exercise and lifestyle and
Yes.
nutrition is a modifiable factor. And their contribution to brain health, and also to understand non-modifiable factors such as gender, sex, genetics,
Yes.
and so forth. So this is one example of a large study that shows that lifestyle in the form of exercise not only produces healthy effects in terms of general health, perhaps cognitive performance, because there are studies that show exercise and cognitive performance,
Yes.
but it also shows neurophysiological underpinnings in the form of brain activity. And it also raises some other questions in terms of the long-term effects of that benefit, and how does this benefit translate to everyday activity and functioning, and indeed, does it on the long run help delay the onset of cognitive decline as a result of
Yes.
aging?
All these studies are done. They're scientifically produced by academics. Why do so few people take cognizance of all the work that you do? Not you as
Yes,
in
we understand. Yeah.
general.
Yes. So ideally, then, all of us should be exercising. All of us should be watching our diet. All of us should be watching our
Yes.
hearing and vision, because those are two actually modifiable high risk factors for dementia. All of
Stress?
us. Yes, stress, because there's research that shows that long-term stress exposure is a factor that inhibits health, and
Yes.
the levels of cortisol may affect brain health as
Yes.
well. It's a very good question. It's the same question: why do we continue to smoke when we know that there are studies that,
Right. What is a neurogenic communication disorder, and is aphasia the same?
Okay, so neurogenic, the term neurogenic refers to the fact that there are some conditions that develop because of a condition that affects the functioning of the brain.
Yes.
So the term neurogenic communication disorders are the types of communication disorders that are generated because there is some damage to the brain. So neurogenic communication disorders can include language disorders like aphasia.
Yes.
Can include motor speech disorders like difficulty in
formulating
the words and the and speech. It can include voice problems that are generated because there is decreased capacity in breathing as a result of a stroke or a brain injury or other injury to the motor tracts that affect the breathing mechanism and phonation. So it's a general term, and conditions such as brain injury, stroke, Alzheimer's can result in neurogenic communication disorders.
Right. We often hear people saying, "Oh, I've forgot my words," and very disturbingly to me, particularly referred to in a very flippant way as, "Oh, I've probably got Alzheimer's."
Right.
I think anyone who's lived with anyone with Alzheimer's will never, ever be flippant about this most debilitating disease where you see the demise of somebody right in front of your eyes. So I wanted to ask, what are the different types of aphasia, and when is it considered mild and when is it considered severe?
Okay. It's a very comprehensive question. So aphasia, let's give out a general definition for the audience. So aphasia is a term that is used to describe a number of language disorders that are typically acquired due to direct injury to certain parts of the brain involved in language, but also due to damage or injury to networks associated with language function. It can affect production, language production, whether it will be oral production, verbal production, or written production. And it can also affect comprehension, auditory comprehension, the ability to listen and understand, but also written comprehension. So aphasia can affect both production and reception and comprehension in the form of oral, verbal, and written language. Conditions such as Alzheimer's can affect and create aphasia, strokes, neoplasms, tumors, and other conditions that affect the brain. Now, in the decades ago, there was also a term called developmental aphasia.
Yes.
Which is no longer used.
Yes.
And the term developmental aphasia was used to explain, to attempt to explain children who had difficulty in language of unknown etiology.
Right.
Okay. Then the term was substituted with SLI, specific language impairment, and then in the recent years, that term has been abandoned by some. It's not a uniform abandonment yet to the term of language learning disabilities. So this is a nice segue to talk a little bit about the European SLT Day.
Yes.
So the term speech-language therapy versus speech-language pathology, it's often used to describe the profession of communication disorders. Speech-language therapy is a term that is used a lot in Europe.
Yes.
Speech-language pathology is a term that is used a lot in Northern America, Canada, and the United States. Canada and the United States moved started using the term about 50 years ago, speech-language pathology versus therapy,
Yes.
with the understanding that this is a profession that has theory behind it, that it's informed by scientific practice, and it's not just therapy.
Yes.
There is a theoretical framework that guides our treatment approaches. So there is, in Europe, we have an organization called CIPLOL, which is the permanent committee that encompasses all European professional associations of speech-language therapists. And CIPLOL was created about 32 years ago or so,
Yes.
and has set March 6th as the European Speech-Language Therapy Day. So that was last Friday,
Yes.
and the days before and the days after are supposed to generate more public awareness for speech-language therapy as a profession.
Yes.
And in Cyprus, we have done a lot of through the years, a lot of PR events. This year, we're focusing more on media events, newspaper and radio, TV, and types of outreach activities. This year's theme was learning disabilities.
Yes. On that note, is there a lot of differentiation with speech pathologies in Greek as opposed to other languages? And you being fluent in both, if not more, languages, how do you evaluate whether somebody actually has some kind of aphasia?
Okay, so how do we, I guess the broader question is, how do we evaluate a language disorder?
Yes.
Whether
Language
it's
and
aphasia.
speech, yes.
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 So we have evaluation protocols. We have tests that we use depending on the skill that we want to evaluate.
Yes.
So there's different tools that we use for children versus adults.
Yes.
And different tools to differentiate the type of speech disorder.
Yes.
There's different types of speech disorders, and so we have tools to differentiate. Different ones for children, different ones for adults. Same thing for language production versus language comprehension. So you've mentioned earlier that what if somebody is experiencing the tip of the tongue phenomena of having a difficulty finding a word?
Yes.
And in normal adults, the term that we use now is neurotypical.
All
adults.
right.
The neurotypical adult, it's expected that during the week you may have some events of forgetting the right name, difficulty retrieving the word, and
Sorry, I just want to clarify, what age are we having these difficulties? Are they across the board, or is it expected at 60 and not at 20?
right. So even a 20-year-old will have on occasion some difficulty coming up with the right name. But as we age, this becomes a bigger complaint. And actually, in terms of cognitive or language complaints of older adults, meaning adults over the age of 60, 65, is that they have difficulty finding the right word, remembering people's names, and then losing things, misplacing items. Those are the common complaints of healthy older adults in terms of everyday nuisances that occur that makes them think, oh my gosh, I'm losing my mind, something is wrong
I can
here.
tick all three.
So, and one might also associate some of these events with things such as fatigue,
Yes.
sleep deprivation, emotional stress, hormonal changes. So, but to the extent that these events become problematic, to the extent that these problems interfere with daily functioning,
Yes.
this is usually when people seek help. and they go to their physician and they say something's off, I'm having considerable problems finding the right words, or they're seeing that it interferes with their activity. So we have tests that we speech-language pathologists use to assess word finding. And
is that the first protocol? Is that a doctor would do? He would send somebody who presents and says, I'm not remembering and I'm having these difficulties. Where would they be sent?
So the first thing, usually what we suggest to people who are experiencing problems is first to meet with their private doctor, with their primary care provider.
Yes, okay.
And because sometimes these difficulties may be a result of certain imbalances. So, for instance,
chemical imbalances?
Correct. So there might be some metabolic issues.
Yes.
There could be some difficulty with hormonal types of issues.
Okay.
And so we want to, part of that, this is an international protocol, right, where you check, you do, the physician orders laboratory tests. Yes. The physician also can, depending on the results, and also taking the history of these events,
yes.
of these difficulties, can determine to order a CT or an MRI scan.
Right.
So the combination of the history, the lab results, the imaging studies, and then ideally they need to refer for a neurocognitive assessment. And at that point you have a comprehensive picture of the person's level of functioning medically, but then also cognitively. And also other aspects, for instance, depression and anxiety need to be taken into consideration.
You preempted my next question, which was how much of a role does that actually play?
Mental health is a huge issue in brain health and active and healthy aging.
Yes.
And actually in life in general, right?
Yes.
So what sometimes people don't realize is that the same areas and networks that are engaged and affect emotion are also involved in cognition and language. Yes. And so certainly anxiety and depression can contribute to clinical symptoms of memory decline or cognitive decline. In some cases with individuals who have diagnosis of dementia, there might even be presenting symptoms. So the first symptoms might be symptoms of depression. But there needs to be a good differential diagnosis to be able to understand the contribution of depression and the contribution of actual dementia to the clinical picture.
What are the most common motor speech disorders, and how does one go about rehabilitation? Okay.
Motor speech disorders, and I assume you refer to acquired motor speech disorders.
Yes.
The two most common are the apraxias and the dysarthrias. There are different biological mechanisms that cause these conditions. And like in everything else, first there needs to be accurate diagnosis. And then there are treatment protocols depending on the condition and the age of the patient in order to create first hierarchical treatment methods and then the ability of the individual to implement those strategies into their everyday functioning. So there are evidence-based protocols that we use in order to first of all assess and then treat the conditions. Conditions such as strokes, all those that we spoke about,
yes.
can result in different types of dysarthrias and apraxias. And sometimes they can co-occur. It is possible to have both.
Wow.
Yes.
Memory is, of course, fascinating. It's a whole, I think, discussion in itself. It's very complex, and it was part of a book chapter that you wrote on cognitive communication disorders. When did you actually move your work to the speech-language pathology? Or has that always been?
Yes, okay, so a little bit of, yes, my studies, as you mentioned earlier, are all in communication disorders. And so I started studying memory more intensely during my master's studies. I was fortunate when I started my master's degree at the Southern Illinois University at Carbondale to be offered a 20-hour paid internship at the Center for Comprehensive Services. So that was a center that was a specialty center for people with traumatic brain injuries. I was 21 years old at the time, didn't know anything about traumatic brain injury, and I was shown a 1-hour introductory video. And then I was given a whole bunch of assessment tools or tests to study. And then I started seeing patients as part of my internship. And it was at the time when in the U.S. you could be assessing a patient for weeks, for days and weeks. It was before managed care came into practice.
Yes.
And so there was a lot of leeway by the rehab centers to spend a lot of time on assessing or making treatment plans or on treating patients for a long period of time. And so I became fascinated by the population. Most of them were my age peers because traumatic brain injury affects younger individuals.
Yes.
Some of them reminded me of friends that I had in Cyprus. And the biological substrates of brain injury were totally fascinating to me. And so one of the things that they had in common, all of my patients, were memory problems. And me, as a speech-language pathologist, I was asked to develop memory treatment programs.
Wow.
Assess memory and treat memory. And
yes.
So that's how my interest in memory and acquired brain injury was developed. And so I did my master's thesis in that area, and then I continued on. All of my work has memory involvement in it.
Do you think that there's going to be any sort of solution for Alzheimer's?
Oh wow, that's the hope, that isn't it? There are two hopes. One is that there will be a medicine, some kind of medicine that will stop the progression of the disease. We don't have a medicine yet.
Is there a reason that we don't have one? We've managed to find cures and medical treatment for AIDS, retroviral drugs. We've got this, we've got that. Okay, I understand we're working on corona now, but Alzheimer's been around for so long.
It's amazing, isn't it, that there are so many efforts, and there's a shift now looking at people at a younger age.
Yes.
So to try and understand what happens decades before the symptoms occur. So there is this effort of finding medications that will either stop or hold the progression of the disease,
yes, or
prolong the functional ability of the individual. And some of the medications that we use today, like Aricept or Donezabel or Ebixa, the goal there is to hold the symptoms,
yes,
and help the individual become or maintain their level of functioning for longer. Yeah. So there are these two categories of medicines then that are being looked at, but then also the big impact of research on brain health. And so studies like the one you've mentioned before with physical activity, our contributions in the literature in terms of understanding the factors that help people maintain their brain health and hopefully delaying the presentation of symptoms is also something that the community is striving for. So the prevention, maintenance of brain health, delaying of the effects of aging in terms of cognition, taking care of sensory issues like hearing and vision loss, watching your physical health, watching out for your emotional health.
Do you believe that social media has a negative impact on our mental health?
I'm not an expert on social media, so I cannot, I'm a consumer of, I try to be a consumer of social media, and inconsistent albeit, but
maybe that's the key, that you're not consistent.
I've tweeted for our show today, and I'm have it on my Facebook, but I cannot say that I'm a master of using social media. Are you aware of studies that show a negative impact?
No, but talking to you, it makes me think that it's something that I have to actually explore a little further, because we do have so many people just sort of aimlessly flicking through their phones on a continual basis, even if they're surrounded by other people. And I'm wondering how that actually affects our brains, and how much we actually think, how much we read, how much we communicate with one another.
Yeah, I know that there are some studies that showed that, for instance, during the holidays, social media, with everybody putting up their happy family moments, that if you don't have access to that kind of a social network, that it may make you feel lonelier or sadder. But to be honest, I don't want to talk about things that I don't feel like I have the expertise to talk about. So I'll be making speculations with you, and I don't know that that's appropriate.
I'd like to say thank you so much for coming onto the program today. It's been so interesting to speak to you, and I hope that you'll accept the invitation to come back and discuss other brain traumatic injuries in more detail another time.
It's been my honor. Thank you so much for the invitation.
Thank you very much for being here.
Thank you, my pleasure.
Dr. Fofi Constantinidou, Professor of Language Disorders and Clinical Neuropsychology, Director at the Center for Applied Neuroscience. What an honor. 22 minutes past 1. A reminder, you're tuned into RIC Classic 88.2, and we are going to continue the program now with the variation Brillante with Stephen Hogue. Thank you so much for watching.